Hello, I am Sonia Petronio. This is the PCR webinar supported by Medtronic on how can we optimize coronary access after TAVI. It's a pleasure for me to be with you this afternoon, together with Daniel Blackman from Leeds, UK, and with Gilbert Tang, New York, United States. We've got an interventional cardiologist and a surgeon. And our purpose today is to discuss how we can access the coronary arteries after an implant of Evolut PRO, all the tips and tricks. You will see cases, and especially how to respect the native anatomy of the aortic root, and how the impact of the native aortic root can affect positively the access of the coronary arteries. So I would really like to begin because I think that we have a lot of things to say, and especially a presentation of an interesting case to begin with. So I would like to have Daniel Blackman to begin his case presentation.
Okay, thanks, Sonia. Yeah, so we're going to talk about how we can optimize coronary access after TAVI. And we're going to, as you said, base our initial discussion around a case. So this was a patient who was actually the second TAVI procedure we ever did in Leeds in May 2008 with Jean-Claude Laborde by our side, an 84-year-old man. Now, at the time, he was 75. He'd actually had surgical AVR planned and a stenotomy in 2004, but it was abandoned due to a porcelain aorta. And luckily, he managed to hang on for another 4 years until TAVI was available. He did have some degree of coronary artery disease prior to his index TAVI procedure, and I'll show a couple of angiographic images, but no symptoms of angina. At that time, we weren't using CT. We actually measured the annulus by transthoracic echocardiography and then an on-table TOE, and that measured his annulus at 24 millimeters. So these were his coronary arteries, just a PA caudal and a PA cranial projection before the index TAVI in 2008, and you'll see a degree of atheroma and calcification, particularly there in the proximal LAD, in the PA caudal on the left, and in the mid-LAD in the PA cranial on the right. But we felt this wasn't angiographically significant, and therefore there was no plan for pre-TAVI PCI. So the TAVI procedure went ahead with what was at that stage the way we did a TAVI procedure, which was pre-dilating with a 22 millimeter balloon for a 29 millimeter core valve. We always pre-dilated and post-dilated with the same size balloon, which shows how things have changed. This patient did require post-dilatation. And it's interesting also to look back at, we describe this as a good result, although he did have moderate aortic regurgitation. He actually had a post-TAVI stroke, but it was mild and had minimal effect on his functional capacity. So this was the final result from the TAVI procedure. We probably wouldn't call that a good result in 2020, as he had probably moderate aortographic aortic regurgitation. But despite that, he did do well and was free of symptoms. His breathlessness resolved, and he remained well for 6 years until he developed some symptoms of exertional chest discomfort, which we were unaware of. But then in 2017, he presented as an emergency to a peripheral hospital with chest pain at rest, very marked elevation in troponin, and widespread marked ST depression. He had ongoing chest pain. He had immediate angiography in the peripheral hospital, but they were unable to selectively engage the coronary arteries. And he was transferred to Leeds as an emergency. And I can well recall it being in the cath lab that day when they said, "Oh, we've got a post-TAVI patient coming." And when I heard his name, I recognized immediately he was the second ever TAVI we'd done. So that's the case. And I think, Sonia, you may want to come in and ask what approach we planned.
I was wondering, first of all, it was very interesting to talk about and to see cases that we have done so many ago and how things have changed. But it is, there are a couple of things, and I would say more than one question I would like to discuss with you, because first of all, it is not so frequent, at least it wasn't so frequent, to have a patient recalled for PCI. So, I mean, how many are approximately patients that are referred to us for a PCI or for a coronary angio after performing a TAVI? Can you tell us about it?
Yeah, so I mean, I'll bring on the next slide, which gives some data on that. But I think what we know is that coronary artery disease is extremely frequent. And we've got data mainly from registries. Obviously, now we have data from the randomized controlled trials. And what I'm showing here is from a review article, which is from Gilbert's group, showing that in different studies, the frequency of coronary artery disease ranges between around 40 and 75%. So it's really very frequent. But I think, you know, as TAVI operators, we've taken a progressively more conservative approach to revascularization prior to TAVI. And certainly our approach in my center in Leeds is only to consider pre-TAVI PCI in patients who have proximal significant disease and symptoms of chest pain. And indeed, our current practice is not to perform invasive coronary angiography, but to rely on the CT angiogram to exclude significant proximal coronary artery disease. But despite that conservative approach, it's quite rare to see patients come back for PCI after the procedure. And again, we've got some data here. These are from 2 different single center registries, estimating that about 5% of patients after a TAVI come back requiring PCI. So I think the other important thing to think about, and that's what we're going to really talk about today, is the success rate when patients do come back. And this is where we see that Evolut is probably the most challenging valve to reaccess and to perform PCI. And that's not surprising, of course, because we know that it's not only does Evolut have a long frame that extends up into the ascending aorta, but also it's a supraannular valve, so that the leaflets and the commissures are much more likely to obstruct or hamper access to the coronary arteries. And we have some data on that I'm not going to show chapter and verse on, but from the group in Catania of Marco Barbanti, which showed about 8% of patients there was failed access to perform PCI. But if divided that to valve type, it was 18% of evolutes where they failed to get access, and fewer than 1% of patients with other valve types. So that's why it's going to be important, in particular with Evolut, to understand, as Gilbert will show later, how we can facilitate coronary access, but in the way we do the TAVI procedure, and also to understand, as we're going to discuss in the first part of this webinar, how when we do need to do access after TAVI, what are the tips and tricks?
Yes, I think you're right. And there is another point I would like to underline is that, I mean, we've been treating a very elderly patient, at least in the first years. So we really thought after, you know, they would last other 5-6 years of their lives. And so once we were going to treat the proximal stenosis, then the others really would not matter. But if we are going to treat younger patients, well, this is going to be something that we have really to think about it, because they will have 20 years, 15 years left after a TAVI, and they need to have a guarantee on their PCI anyway and access to their coronary arteries. So you said that Evolut, it is in some way risky. Probably it was more the old generation of this valve, much more than it is now, the actual generation. But I think that anyway, the problem that you have underlined with your previous slide is that sometimes referral centers, peripheral centers, are not able to, or they get in, you know, they have some question mark when they need to perform a coronary angio to a patient that has a TAVI. So I would like to ask Gilbert, because I mean, you've been studying a lot of the position, the anatomy, the structure of these valves. What really the center need to understand and to know, like this, you don't get in a panic and they are able to succeed anytime that they need to perform coronary angio?
Well, thank you, Sonia. We're just going to show you a diagram here that was published in BioGroup in JACC, looking at the both anatomic and device factors and also procedural factors affecting the ability of coronary access. And we've illustrated with this figure here that it depends on what kind of valve, whether it's supraannular, tall frame versus a shorter frame. Also, the distance between the sinuses and the coronaries, the sinus height, and perhaps probably the most important aspect in my mind is the sinotubular junction, which is the top of the aortic root. If there's lots of space there, there will be more room for catheters to engage the coronaries. And of course, something that I'll talk about later will be the ability to align the commissures, because we know that the commissures tend to be the tallest point of these transcatheter valves, and it would be nice not to have this in the way of the coronary orifice, so that you have more cells or more room for the catheters to engage.
Yes, that's very important. There is a question, Dan. Somebody has asked, I think that really a question comes from India. This person asks if we can perform a PCI doing the procedure of TAVI in the same setting. And it is a little bit different of what we are discussing now, but you've been saying that you perform the proximal stenosis in patients that need TAVI. So do you do this during the procedure, just before the procedure, or before or after?
Yeah, I don't think there's a hard and fast rule on that, and I don't think we have any data to guide that. Our practice is predominantly to perform PCI in advance of the TAVI procedure. I think it's purely for logistical considerations. We don't want to have a problem with the PCI procedure and then be unable to go on and do the TAVI or consider it to be inappropriate. We don't want to expose the patient to contrast through the PCI procedure and then add to that with the TAVI procedure. So in most cases, we feel it's more logical to perform the PCI procedure up front and then go on to the TAVI procedure. But again, it depends on the individual patient circumstances. It may be, if you're treating the patient with a valve that more readily facilitates reaccess, you may feel more relaxed about doing it afterwards. And that will give you the option to see if the patient's symptoms resolve. And then occasionally you have patients where, particularly in emergency situations, you feel that the only way to treat the patient is to do everything at once. And we've certainly done that particularly in urgent and emergency cases where we've faced a combination of severe decompensated aortic stenosis and left mainstem disease, where we've done the PCI and the TAVI at the same sitting. And often then we've elected to put the valve in to stabilize the patient and then do the PCI procedure. Because that's the counter argument, I think, to doing the PCI up front, is that if you have a complication for the PCI procedure and you have a patient with untreated aortic stenosis, they're less likely to tolerate that. But I would argue in general PCI up front, but you have to treat each patient individually.
Gilbert, they ask which is the minimum height for a coronary osteotomy to perform a safe TAVI?
Well, I don't think there's a black and white rule. It all depends on the relative proportions of the aortic root anatomy. So, for example, in patients with previous surgical valves, we know the coronary height tend to be very low because all the surgical valves typically are implanted in a supraannular position. But if you have very large sinuses and large sinotubular junction, the risk of coronary obstruction for valve-in-valve is extremely low. For native TAVR as well, I think what we often do not look at, but worth looking at, is the leaflet height. So what I mean is that if you have a very bulky cusp facing either the left main, which is typically the artery that we're most concerned about, is quite tall, even if the left main height is very sufficient, let's say over 10 millimeters, but you have a very tight or small sinotubular junction or very effaced or small sinuses, that leaflet can still potentially obstruct the coronary. So it's not a hard and fast rule about what left main height specifically will be concerned about or excluded from TAVI. I would say, based on my experience looking at a lot of CAT scans, generally the left main height, as low as about 5 to 6 millimeters to all the way up to above the sinotubular junction. So it has a really large range of anatomy. You have to look at it, like what Dan said, individually for each patient.
Yes, I perfectly agree. I think that also when they give us all the measurement for each other, and you have to look all the route, you don't have to look only one measurement. That's absolutely. So let's go in detail on your case. Before showing what you have done, I mean, when you have to perform a PCI or an angio in a patient that is coming like with a non-STEMI, like your patient, I mean, what kind of access do you choose? What do you do? Perform an angiography, orthography before to look exactly? I mean, what is your experience and what you would like to say to all the people that are listening to you?
Yeah, it's a good question, Sonia. I think, certainly at the time of this patient's presentation, and particularly faced with a patient where there'd already been a failure for selective coronary cannulation, that might have pushed me towards a femoral approach, because I think, although I perform almost all of my angioplasty from a radial approach, it can be more challenging to access the coronary arteries from the radial. So there's some advantage to femoral, but I must say now I'm so much more comfortable with radial that I would still go radial. As you'll see in this case, we did go femoral to optimize our chances of good coronary access. I think the aortogram is a very useful thing. It will tell you a lot, particularly with the Evolut valve, about your chances of accessing the coronaries. Often it'll show you where the commissures are. So you'll know if you've got a commissure in front of the coronary ostia, and you can assess that purely from the aortogram. As you know, with the Evolut valve, there's a C marker on one of the kind of upper parts of the frame, and that tells you where one of the commissures are. So that will also give you an idea about whether the commissures of the valve are in front of the coronary ostia or not. So I'd certainly advocate an aortogram, and if I were performing PCI on a patient following TAVI, even if it was for the first time and there wasn't a previous failure, as in this case, I'd do an aortogram. So I'll go forward, with that in mind and show you this case. So this patient, as I say, came across to us, had ongoing pain, dynamic ST depression. So we went from a femoral approach, performed an aortogram. I think the first thing to notice, and this is often the case with Evolut, is there's actually less AR now, 8.5 years after the TAVI, than there was on the day of the TAVI. And you can see that this shows that we can see good filling of the left and right coronary artery. So we don't anticipate that this problem is related to obstruction at the level of the sinotubular junction. And we know that, and Gilbert may touch on this in his talk, that can be a frequent cause of coronary obstruction, although more usually immediate or at least subacute. So here we can see good coronary filling, and it gives us an idea about our chances of accessing the coronary artery. So after this, the question is, what guide catheter are we going to use? What wires are we going to use? What kind of approach are we going to take? And I don't think we have data to make firm recommendations on that. We're relying on our experience. So my usual approach would be to take a Judkins guide catheter initially. For PCI in general, I think, like many operators, for the left coronary artery, I'll use a Voda. I think the first thing to point out here is that we didn't bother trying to access the right coronary artery. This patient clearly had left coronary artery territory changes, was unstable, and there was no need to take time trying to access the right coronary artery. So we went immediately with a guide, and this is a JL35 guide. Now, as we've discussed, you will often, very often, even with the Evolut valve, be able to access the coronaries very easily, depending on the depth of implantation, and particularly depending on the commissural alignment. If the commissures are not in front of the coronary ostia and the valve is not implanted too high so that the sealing skirt is below the choriostria, then you may be able to access very easily, and your guide will slip through the large cells of the core valve or Evolut device. But as you'll see in this case, that wasn't what we experienced, and not surprising given that the other center had failed. The Evolut, the guide catheter initially was hard to get through the Evolut, and you'll see in the upper right panel, even when we did get the guide catheter selectively through the cells, we still weren't able to selectively engage the left coronary artery. But what you will see, even from these sub-selective shots, if you look at the top right-hand panel, you can see there's clearly critical left mainstem disease. There's also probably severe disease in the mid-LAD. And in the bottom of those three videos, you'll see that there's critical disease in the circumflex system, which is highly angulated and looks very challenging.
Well, Dan, I mean, it's all very interesting, and I think that we all have an experience. Definitely, is not long. Everybody has some experience. The number of patients are, I would say, very little, even if it's 12 years or 13 years that we are struggling with TAVI. There is something else. I know it's important, the guiding catheter, and probably there is even a change of measurement depending if you are talking about supraannular valve in respect to an annular valve. We generally choose half a measure less for a core valve in respect to an Edwards, because it's the space is definitely shorter. But is there something else, like particular wire you would use, or something technology that gives you more advantage when you are not able really to directly cannulate the coronary ostia with the guiding catheter?
Yeah, I think that's a really good question. So I think, if you're faced, as we've discussed, sometimes the guide will go in and then it's just like a normal PCI procedure, but often it won't. And you're in this situation where you can't selectively engage. And then I think what you've got to have to do is float the wire into the left coronary artery and then use a guide catheter extension. And I think a lot of these things are subjective. Different operators will tell you different things, but I think most TAVI operators who've experience of performing PCI after Evolut TAVI will tell you that a guide catheter extension is a really fundamental piece of kit. So you can float the wire into either the LAD or the circumflex, any vessel you can get into, and then you can follow it up with a guide catheter extension. And once you've got that guide catheter extension into the left mainstem, then really, you're home and dry. You've got good support, and you can get on with the rest of the procedure. The other thing this case illustrates is that, very often with TAVI patients, you're faced with really quite challenging anatomy. And this is an example of that. These patients often can have very difficult anatomy, and that the guide catheter extension will help you with that too, because it will give you better support for stent delivery.
We are receiving a few questions.
Okay.
One question says that, has the new portico valve has large cells can benefit in preventing coronary stenosis post-TAVI? I mean, are you able to engage it better? This is one question. And the other question is, which valve is better if the balloon or self-expandable, if the height of the coronary artery, it is low as 5 millimeters? So I think that the second one, Gilbert has answered. I mean, it's very difficult to decide which valve on the anatomy, but the one of the portico, would you answer to that?
Yeah, I mean, the portico, as many people know, looks quite similar to the Evolut, but there are a couple of key differences. The first is the cells are much bigger, and the second is that the valve sits lower. It's an intra-annular valve. So both of those factors should make reaccessing the coronary arteries more easy than it is with an Evolut or core valve. Against that, however, what we do now have with Evolut, and we certainly didn't have in 2008, is some pretty reliable and reproducible methods to align the commissures so that we can facilitate coronary access. And I know Gilbert's going to go into that in detail and explain to people how they can do that. So I think Portico, in general, the design makes coronary access more easy superficially, but what we have with Evolut, and it's more specific to Evolut and not available in the same way with Portico, is a method to align the connoisseurs so that we don't have the challenges in the future that we faced when this patient came across to us a few years back from his TAVI in 2008.
Okay, let's go on with your case, Daniel.
Okay, so I'm going to show you what we did in this case, and I think it's a good example of how you can manage patients with challenging coronary artery disease and challenging coronary access. So as you can see here, we weren't able to selectively cannulate the left coronary artery, but we were able to see what we were tackling, which was critical left main, LAD, and circumflex disease. So if you're going to float a wire and then rely on following it up with a guideliner, you want a fairly floppy and responsive wire. And for me, a Whisper MS wire, is a wire I favour. There are many other wires that fit the bill, but in general, you want a wire that's not too stiff and that's very responsive to the torquing. And the Whisper is a wire that fits that bill. So the first step is get the Whisper wire, or whichever wire you're using, into that space around the left main stem, and then use your torquing to get the wire into the coronary artery. Then once you've got the wire into the coronary artery, get your guide catheter extension and follow the guide catheter extension through. And then once you've got that guide catheter extension through, then you can get on with the rest of the procedure. This is standard technique. If you can't get the guide catheter extension through, the technique would be to follow the wire up instead with a small balloon. Use that balloon, inflate it if necessary in the coronary artery to provide greater anchoring, and to get your and that will allow you to have more anchoring to follow up with the guide catheter extension. So in this case, we were able to get the wire into the LAD, follow up with the guide catheter extension, which you can see at this point of the procedure is just sitting at the left mainstem ostium. And then we were able to get a balloon down into the target in the mid LAD, and that provided more support to get the guide catheter extension further in to facilitate the rest of the procedure. Now, we took a fairly early decision in this case that we weren't going to worry too much about the circumflex. This was an 85-year-old man with critical left main and LAD disease, a circumflex that looked incredibly challenging to treat. So after a brief attempt at wiring that, we decided we're going to focus on LAD and circ. So we're pre-dilating here. And then we moved on, because of the very extensive calcification, to prepare the lesion with a non-compliant balloon and with a scoring balloon. Those balloons went up well, giving us confidence to deploy a stent. This is a 3528 Xience drug-eluting stent, and you can see we've used the guide catheter to give us the support to get that into the target lesion. Deploy that stent, then bring that guide catheter, leave our guide catheter there, get the next stent for the left main stem, then bring the guide catheter back with standard PCI techniques, so we can deploy the stent right back into the left main stem. Now, as I say, this patient didn't have any issues beyond the left main stem ostium, so we didn't need to be stenting above the sinutubular junction or anything like that. So we're just covering the ostium. And then we deployed that stent, which, as you can see from this view, went up very nicely. And then we optimized the stent with non-compliant balloons in both the LAD and left main stem. And here's the final result. So we've got a spider view on the left, we've got a PA cranial view on the right, and you can see we achieved a really, what I'd consider to be a fantastic result. Clearly, we've still got residual critical disease in the circumflex, but you have to make pragmatic decisions, as you know, often in percutaneous coronary intervention. So we felt that that should make the difference to this patient. And indeed it did. He made a good recovery. He's had no recurrence of chest pain since then. This procedure was 3 years ago. It's worth showing his echocardiogram. This is 12 years after his TAVI procedure. He's got a mean gradient of 8 millimeters of mercury across that 12-year-old core valve. He's got mildly impaired LV systolic function, and he's got mild to moderate paravalvular leak, probably slightly better than what he had the day of the procedure in 2008. And as this guy was the first patient in our center, to reach 10 years post-TAVI. He was generous enough to come in with his wife, and the cameraman made us do this slightly embarrassing celebration, but nonetheless, it was nice to see him 10 years after a TAVI, and he's still going strong in 2020, 12 years post-TAVI.
That's lovely, Dan. Really, really interesting and nice to see all these people that live so long after all that. There are many questions arising. So before going to the other talk, I need to ask to Gilbert. They said that is the sinotubular junction has, you talked about it, of course, with the importance of sinotubular junction. So what they ask is there a minimum diameter that after which you are not to perform a TAVI?
Yeah, no, there's no exclusion criteria in terms of sinotubular junction for TAVI procedure. I think what you need to look at is not just the sinotubular junction diameter, but also the sinus height. Think of the aortic root more or less like a cylinder. And so you have to put a TAVI device inside, and of course you have the native leaflet and the coronaries. If your sinotubular junction is narrow and your sinus height is tall, you should still be able to have plenty of room to reaccess the coronary from above the valve frame or even from around it, because there's really nothing to interfere. The most challenging part is you have a small sinotubular junction and a short sinus height, so the amount of space you have after you implanted the TAVI device, whether it's balloon expandable or self-expanding or even mechanical expandable, it's going to be less, less room than available with a larger root, irrespective of what the coronary height is. So again, I just want to caution anyone to have black and white cutoffs, because now that we learn TAVI done over hundreds of thousands of implants, we know that it's the specific anatomy of each patient. Majority of the time is very benign. You can do any device in and should be fine. But there will be situations where prophylactic left main protection may be a prudent thing to do, or maybe a certain anatomy where a certain device may risk, sinotubular junction tear leading to a dissection, or a coronary obstruction because of the anatomy involved.
Well,
I think the other point, Sonia, if I just come in briefly, sorry to, Gilbert touched on this. It's important for people to understand not just the patient's anatomy, but also the characteristics of the valve that they're implanting. So you need to know about the patient's sinotubular junction height, diameter, left main height, sinus of valsalva diameter, but also about the device. What's the height of the skirt and ceiling skirt in that device? What is the waist of the device for the long devices like Portico and Evolut, so you can understand, what your risk of jailing at the sinotubular junction might be. Secondly, what your risks are of preventing reaccess to the coronaries. And thirdly, particularly as you touched on in the introduction, when we move into younger patients, we need to think about the feasibility of TAVI and TAVI. So it is important for the people watching and TAVI operators in 2020 to understand not just about the CT's characterization of the patient's anatomy, but also to understand the exact details and dimensions of the valve they're implanting.
Now, before getting in details with the commissural alignment, there are a few questions on tip and tricks. They are meant to choose a couple of them. One is they ask you, if you use the extension catheter, do you have some time and instability? Some ischemia, is this too bulky, or it is fine to do it in a few patients?
Yeah, it's a very good question, and it depends on the patient's anatomy, of course. So, if the patient has got significant left mainstem or proximal LAD disease, then you can plug that with the guide catheter extension, and you need to be aware of that possibility. Now, you should still have, some perfusion through it, but that's definitely something to be aware of. And you need to keep an eye on the ECG and on the pressure. Now, the pressure is less helpful because you will inevitably have damping of the pressure from the guide catheter with the guide catheter extension in it. But the key thing is to watch the ECG and be alert to the possibility of ischemia. And again, that's where you have to tailor your approach to your patient. Now, if you have a patient where you're treating the LAD, but the left main stem is wide open, then you can freely engage your guide catheter extension selectively. And very often what you need to do with a guide catheter extension is to bring it in and out, take it into the LAD to deliver your device. And very often the most effective mechanism is to take the guide catheter extension beyond the target lesion, deliver the stent beyond the target lesion, then bring the guide catheter or extension all the way back and bring the stent into your lesion to deploy the stent. So that's the kind of approach that I'd advocate.
Well, there are other questions I can answer quickly to is they've been asking if you can perform an IVUS, and I can tell you there's some description of even rotablator done in a PCI after TAVI. So if you are able to engage the proximal part of the coronary ostium, the performance of the PCI, I don't know if you've done it, is similar to any other PCI. Of course, there are some tips and tricks as we asked, but also some other has asked if you can use a 7 French catheter, and I think it's absolutely no problem about that. Sometimes it's even useful because it holds better the situation, has more, it helps you a lot in engaging the coronary artery. So let's go now to something interesting. That is what the purpose of what we are doing now and we will do in the future, as to try to understand and to the impact of the native anatomy of the patient. So Gilbert Tang, as a surgeon and as an expert in TAVI, can you please tell us everything?
Well, thank you, Sonia. My pleasure to present some of our group's research work that involves commissure alignment and coronary access. So you can see that with the previous slide on the anatomy, that there are a number of procedural factors and device factors involving coronary access. And this is an app that was developed by Dr. Sharma and Dr. Kinney, both interventionalists in our group, called TAVI Cath 8. You can download for free on Android or iPhone. That shows you some of the tips and tricks that we've learned from Mount Sinai on how to reaccess the coronaries after TAVI, both balloon and self-expanding valve. And it's been very helpful in some of the trainees, but also some of the cardiologists out there not familiar with TAVI, who know how to get themselves out of potentially serious situation. But what we found, at least our experience, is commissure alignment really simplifies the ability to perform coronary access. And you can see that in the distracted tutorial that it can be highlighted in both situations, including redo TAVI. So what you see here is some of the papers recently published on looking at if you have a commissure facing one of the coronaries, it does make coronary access difficult. For example, with the Evolut device shown here, and you can see here, this is a CT study looking at multiple different cases, and about 20% of the time that there's one commissure facing the coronary with the Evolut system, and about even for balloon expandable valve, about over 10% of the time. So what we believe is that commissure alignment may matter for future coronary access and maybe even aortic valve reintervention. So why do we do this? Well, in surgery, as a surgeon, we do it every time. And that's why after the surgical valve replacement, coronary access is very easy. And also TAVI SAF or valve-in-valve TAVR is relatively straightforward. And if you have no commissure or post-overlapping coronary, it was going to reduce the barrier to reaccess. It may even have long-term on durability. There's some studies showing that there might be more likely of potential subclinical leaflet thrombosis if your commissures are not aligned properly. And of course, if you want to consider basilica procedure or leaflet splitting, it's not really feasible if you have a commissure or post in the way facing the coronary. So here's an example of a figure that these both valves, surgical valve that had a basilica procedure done on the bench. And you can see that if you have a commissure or post facing that split portion of the leaflet, you may still obstruct the coronary, even though you do a basilica procedure. So commissure alignment is important even in potential valve-in-valve TAVR. So this is a paper that recently published this year on called Aligned TAVR study. We looked at 3 different valves. We looked at the SAPIEN 3, the Evolut, and the Accurate Neo. You can see here over 800 patients. What we did was we crimped the SAPIEN 3 with one commissure at different clock position, 3, 6, 9, and 12, to try to see if we can intentionally align the commissures with the commander system. With the Evolut, we have a minority of them had the flush port facing at 3 o'clock instead of conventional 12 o'clock to see if we can better align the commissures. And Accurate Leo, we look at one of the 3 commissures orientation tracking during the flow before and after the deployment. And what we found was that using the CT co-registration technique, meaning that instead of using post-CT, which we have done a few of them, we use a pre-CT to try to mathematically determine the commissure alignment. And in terms of the SAPIEN 3, we found that despite trying to put a different clock orientation, there's really no consistent manner that we can align the commissures with the SAPIEN 3 system. With the Evolut system, what we have done is that we look at the CTAP being represented on the commissures, as Dan has mentioned. And if you notice how that also the head marker at the time of deployment on fluoroscopy, that's the outer curve with that dark band, is an outer part of the aorta. You can see, look at center front or in the inner curve. And what we do, we try to determine the relationship between the two. And you see that when the valve is being loaded with the Evolut delivery system, the CTAP is approximately 90 degrees off from the head marker in a clockwise orientation. So why does this matter? You can see that majority of the time when you deploy the Evolut valve, the head marker is located either in the outer curve or center front. Minority of the time is in the inner curve or behind you in the center back. And that has a relationship where that CTAP, which is one of the commissures, end up. You can see majority of the time that is in the inner curve of the aortic ascending aorta, some of the time and the outer curve. And that matters because I'll show you in the next graph that if you have the head marker at the inner curve or center back, those are the red bars, you had a much higher likelihood of having a severe overlap with the left main or the right coronary, versus if your head marker is in the outer curve or facing you at the center front, you can see the green bars is much less likely to have a severe overlap with one of the coronaries. And so what we did essentially is, instead of going at 12 o'clock with a conventional method, we went 3 o'clock, rotated at the time of when we insert in the delivery system. And the idea is to try to get the head marker to the outer curve for center front as much as possible. So in a classic deployment or LAO view, your head marker will be outer curve or center front. In the Cusp Overlap view with the RAO projection, your head will be in the center front. So the idea is to try to land that CTAP when it's released to the inner curve of the ascending aorta. So where is this flush port at 3 o'clock? So this is what it shows here. It's on the gray handle. And you can see that it's right there, and we put it at 3 o'clock away from the operator when you insert into the femoral artery. After that, you just let the delivery catheter work its magic around the arch. You can see it here in this video that you track. And essentially, you should be able to track the head marker to the outer curve in the LAO classic projection or Cusp Overlap view, meaning facing you directly. So if you do that, you essentially land the CTAP majority of the time at the inner curve and get good commissure alignment. So this is an animation. It's about a couple minutes long to show you how this works. You can see this was in sort of 3 o'clock position. You can see the head marker is usually in the outer curve of the descending aorta, or at least in the back. And you can see that it tracks across the arch, and doing so will get the head marker at the outer curve of the ascending aorta. And when you go across the annulus, if you use the Cusp Overlap technique, which is shown here in this animation, the head marker will be locating in the center front facing you directly. So you just essentially deploy the Evolut valve in a standard fashion. You can see that here. The light blue represents the membrane septum that you try to avoid. That's why you try to implant usually between 1 to 3 millimeters depth. Of course, it depends what the septal length is, where the conduction system is located. And as you deploy, you can see that at the 80% mark, you should have pretty good commissure alignment. So you can see here, this is the control pacing part of the Evolut delivery deployment. You have annular contact, and then you go quickly to 80%. So once you have 80%, you assess your implant depth at the non-coronary cusp and the left coronary cusp. And you can see now, going back to the anatomical illustration, that you should be able to get good commissure alignment. And you can see that if you are pleased with the result, you can release the valve on the standard manner. Notice that you can see the head marker at the animation that would be at the outer curve. And you can see that also one of the commissure tabs is pretty aligned with the native commissures here. And when you release the valve, you'll also notice that the C-tab would be located at the inner curve of the ascending aorta. So here's the release. You do it at a very slow, methodical fashion. You can see that the C-tab is the inner curve of the aorta, and that's what you're aiming for, because that represents one of the commissures. So what we've done now, this is the latest data that at our own center. We have over 300 consecutive cases now. We started doing this last March. And the number of times that we have to rotate the catheter in the descending aorta is less than 10% of the time. But what we found, we increased the rate of head marker in the outer curve center front from 70% to almost over 94%. And we dramatically also reduced the incidence of severe coronary overlap from 38% down to 21%, one of both, and left main from 31 to 13%, the right coronary from 20 to 13%, and only about 5% of the time you would have an overlap with both coronaries. So you can see here, this is an example case. This is done with a 29 Pro in a low-risk patient. It was part of a low-risk trial. You can see it was done in a standard manner with an LAO view. And you can see the head marker was in the outer curve at the time. And when we released the valve, this is done taking a coplanar projection. The C-tab is the inner curve. This patient had a post-CT study as part of the CT sub-study. And you can see that the commissures are well aligned using the post-CT to confirm. And in fact, this patient required coronary angiography shortly after the procedure because of angina. You can see there were no coronary issues, but you can certainly see it was very easy to access to both the left and right selectively. I'll show you one more case. You can see this is a 23 Evolut Pro with a Cusp Overlap projection. You can see here with using this deployment, again, the head marker was facing you directly. And you can see when you release the valve at the LAO projection, the head marker will be in the outer curve. And you can see that when you do the cine of the valve at the end, you can see that the C-tab again would be at the inner curve of the aorta. So there are potential limitations with this technique. You can see this is only a transfemoral approach. It hasn't been tested in alternative access. Our alternative access rate is well less than 3%, so it's really unusual to require that. Also, of course, iliofemoral tortuosity or calcified vascular anatomy may limit the ability to track the head marker at the outer curve. So I don't encourage anyone to force rotate the delivery catheter once you're in the patient. But certainly you can see from our data, over almost 94% of the time, it would get to the right place and achieve good commissure alignment.
Oh, well, that was very, very interesting. Can I ask you a question?
Yes, of course.
I mean, you've been showing, first of all, that it is not easy with all kind of valves. I mean, Evolut has the advantage of having this pad that is always in a position of one commissure. Is there, in your experience, some positive or negative anatomical situation where you can have some advantage or disadvantage to do your commissural alignment?
Well, I think the main advantage is that, as you can see in the animation in our data, that it's not, it really anatomically aligned with the native commissure. So you're facing the bottom part of the evolut valve, just like with the native leaflets and the sinuses. So access is very easy. Now, one thing we have that in detail is bicuspid valve, which we know the coronary anatomy, it can be different and not typically at the center of the sinus. So in those cases, even with commissure alignment, you may still have a coronary preferentially located near one of the native commissures. Of course, we cannot change the native anatomy, but one thing we can try to do, at least from a transcatheter valve standpoint, and what I would call achieve what a surgical-like results would be. Like in surgery, we would never misalign the commissures. So I don't think we should do that also with the transcatheter valves.
Okay,
Yeah,
there have been some questions about the difference between using the traditional three-cusp alignment or the overlap cusp view, and you have already answered to that. Would you add something? They were asking if the cusp overlap would add something more to this technique.
Yeah, so no, the 3 o'clock flush port insertion doesn't change the Cusp overlap technique or whichever technique that you prefer to deploy the evolut. It's just a way to insert it into the delivery system into the groin. And once it's in there, you just track the delivery catheter however way it tracks. You don't try to force it at the 3 o'clock position inside the patient. That is one thing I want to emphasize. You just literally put it in there at 3 o'clock and let the catheter go whichever way technique you deploy the valve. We do Cusp overlap technique routinely. We publish a paper on that, on how to do it, because we dramatically reduce the pacemaker rate with Evolut from low teens to now same rate as SAPIEN 3, about 5 to 6%. So
we have a few minutes left, Dan, and there have been many questions, and of course, the tip and tricks are the main issues. And somebody has asked that we didn't have any discussion on the right coronary artery. So if there's something we would like to add when we perform a PCI on the right coronary artery, because of course we were talking about the left, because your case was on the left coronary artery. Do you think there is a difference in behavior, in percent of success?
It's a good question. Yeah, I mean, I think that, again, the key emphasis of this webinar should be, I think, that prevention is the best medicine, as always. And so I think adopting a commissural alignment technique is the first step. But obviously, as in our case, sometimes you haven't done that historically, and then it comes down a little bit more to chance. I mean, in terms of the right coronary artery, again, it depends if the commissure is in front. The right coronary artery takeoff is normally higher, so that can facilitate access. On the other hand, when you're normally accessing the right coronary artery, you do so from below, as we all get trained as residents to rotate clockwise and draw back, pull back on the catheter to engage the right coronary artery. And you can't do that if you've got a valve frame there. You need to access the right coronary artery from above. I'd still start with a JR4 catheter if I was trying to get into the right coronary artery post-TAVI. But if I was unsuccessful, then I may need to take a catheter that's going to point down rather than point up. So that could be an RCB catheter, right coronary graft catheter, or a multi-purpose catheter, or possibly an Amplatz like an AL1 lifted up so that the tip of the catheter is pointing down. But the other rules would apply the same. I think that if you can get direct access, that's good. But if you can't, have a low threshold for floating a wire and following up with a guide catheter extension.
Okay, yes, I think that we needed to talk about a little bit of the right coronary artery, because it's always it can be this. It can happen both events. There are some questions about bicuspid. So one question is, if we do a TAVI, perform a TAVI with bicuspid, and we have a short coronary height, and we should perform a high implant of the TAVI. Should we do that, or we would change the way of implant as the height it is short? Good question.
Yeah, I mean, I think I mean, obviously the topic of this webinar is coronary access. With a bicuspid valve, usually coronary obstruction is less of an issue because most commonly the sinus of Valsalva is quite spacious. So there's less risk of coronary obstruction. And I definitely support what Gilbert was saying, that in general, the diameter of the sinus of Valsalva, the dimensions of the sinus of Valsalva, that's more important than the coronary height. But it's obviously, taking all things into consideration. But usually with bicuspids, you've got a large sinus of Valsalva, so there's less concern about the coronaries. Now, that does give you the option of deploying the valve high, but I don't think that's so much about coronaries. It's more about where to deploy the valve to optimize anchoring and sealing. So, and there is a theory, which I think I would support, that you can often get better anchoring and sealing in bicuspid anatomy with a deployment that's in the cusps rather than at the level of the annulus. So I think it's not really about coronaries with bicuspids, but I think you can often deploy higher with bicuspids, get a better anchor, better seal, and less interaction with the conducting system in the LVOT as well. Gilbert, I'm sure you've got a view on that because you'll understand the anatomy of a bicuspid a lot better than me.
No, not. I think my comment on low left main is, where is this left main? Is it in the middle of the sinus, or is it actually towards one of the raphe or the commissure? Because then, as Dan said, sinuses tend to be larger in these patients. Sinus height, their root, sometimes they have aortopathy, so the roots can be quite large. But if the coronary is adjacent to one of the commissures, because sometimes the right or the left, then you have to be really concerned about the leaflets themselves potentially becoming a door to shut off that coronary orifice, irrespective of how you implant the valve. So I think that's something that we consider very carefully.
Yes, I think this is a good point, because sometimes you recognize bicusp just by the origin of the coronary access. You understand that there's something wrong when you get a mixture between tricuspid and bicuspid, just looking at the coronary ostia. This is really true. There is one more and last question about cusp overlap. It is asked, do you still, with cusp overlap, do you still need to worry looking the height of the membranous septum, or it's an advantage?
Oh, I guess I'll go first with this question. So we routinely, at least our center, measure membrane septum length for two reasons. One is that if the membrane septum is long, you have a little bit of margin of error to implant the valve, whether it's Cusp overlap or the classic technique. We do that with Cusp overlap, and we generally target our non-coronary depth between 1 to 3 millimeters in general. And based on my experience, most septal length are between, on average, 5 millimeters or longer. So you have some margin of error to implant the valve. 3 millimeters, that I would say is optimal. I'm not advocating, and I never done a supraannular deployment, and I don't think that should be the message here. So the septal length does matter, but I think in general, if you target the Evolut implant between 1 to 3 millimeter at least in our experience, even with patients with right bundle branch block, we had not had a problem with pacemakers. In fact, now we don't even put in a neck line pacer. We put it in the groin like a Sapien case, and we take it out at the end if there's no conduction system changes. Dan, what are your thoughts?
Well, I think it's been a good advantage, this thing of the cusp alignment, the membrane septum, all that we have learned in these last years. I think we'll have to wrap up now, because we're crossing the whole hour. And I think that we can say today that, first of all, the anatomy per se of all the root of the patient is very important. We learned that we have to respect the position. Like this, we can have the advantage with a few tips and tricks to give the opportunity for any patient to have a PCI or coronary angio in his years after a TAVI implantation, and as you said, also in a possible TAVR and TAVR, which is even perhaps more important, looking at patients that are getting younger and younger. I think that we've been learning a lot of things in these last years. As you were saying, we have learned about cusp alignment, commissural alignment. We are getting probably having better results and optimizing this very good and successful technique. So I have to say thank you to both speakers, Daniel Blackman and Gilbert Tang. Thank you to the time we've passed together. I hope we have answered possibly all the questions. If you have more, you just have to write to PCR and we'll try to answer in the future. Thank you for the afternoon and good evening.